Hi, I'm April Black, and today I'm talking about the alternative framework for evaluation and management services that will be implemented in 2021 by CMS. There's a lot going on with evaluation and management services, and for many providers, this is their bread and butter for every day. So this is an important topic. Although if CMS has delayed the code set and the payment model changes that will occur in 2021, it's not too early to begin preparing and planning. So there are three choices that are outlined in the framework for physicians to document. There's the old and famous documentation guidelines of 1995 or 1997 that we're all familiar with. The system is currently not working, but it remains an option for those providers who do it well and understand it. Then there's an option for time. Time is a unique factor in CPT. There are time-based codes, and then there are estimated time values associated with certain E&M codes. Now, those estimates are based on the intra-service time of physicians and is supposed to represent the practice, or should I say the current practice standards, although it doesn't. Most of the estimated times that are associated to the established and new patient codes in CPT do not align with the current state of patient flow in medical practice, especially in the outpatient setting. So that still remains an option if providers are comfortable and able to estimate and make patient flow match to those times. Then time documenting is a good mechanism. But today we're going to focus on the medical decision making and how it will make your life a little easier as a physician. It'll make the coder's life a little easier, but the same stakes are at play. The coder is still going to be responsible to identify the important factors of diagnostic relationship as documented by the physician. So this is a partnership and a learning curve that everyone's going to go through together. This is nothing new. We have always talked about the reasonable and necessary services and medical necessity. This is important for coverage of any service. The initiative to reduce the burden of documentation on the provider is going strong under the Patients Over Paperwork initiative by CMS. As a part of this initiative, providers are less accountable to the medical history and components of documentation. This broadens their time to be able to focus more on the clinical relationships that really impact care. Now, under this initiative, I want to remind everyone to keep in mind that neither the proposed changes or the current documentation guidelines or the reduction or burden of simplification guidelines allow providers to use collected or otherwise created information from others towards their medical decision making. Medical decision making is a unique thing that is performed by the physician or clinical staff, and it incorporates a lot of thought process, a lot of evaluations, a lot of consideration for contraindications, for risks, for complications, for quality or severity, the patient's mortality risk, all these things that are considered when a medical decision making takes place is now going to be more than ever important as we move into 2021. The medical decision making isn't just about the presentation of the patient and the diagnosis. It's about the condition and the treatment as well. It's about the condition's progression and their context of whether they have already failed conservative measures, if you're progressing their treatment because their disease is progressing, if they have manifestations or other reasons or new symptoms of acuity. These are going to be more important than ever for a physician to document to support the complexity of evaluation and management services upon the implementation of the new payment model for their bread and butter could really be affected in the event that these things are not captured. So let's remember, the objective is still to document less and save time. So let's talk about what is truly required. What is medical decision making? What needs to be written down? What needs to be represented in an audit? What is the payment and coverage decisions auditors and contractors going to be basing their decisions on? What are they looking for? I have spent many years working for providers and working for payers, and in my experience, and according to the new documentation, simplified documentation guidelines, these are the areas to which all medical decision making should include. So let's just briefly go over them. The presenting problem with the description of the affected system and the acute illness or the relationship or etiology to any complications or chronic conditions that are under care. How many and what are they affecting? Are they intermingled? Are they singular systems? Describe and connect with these individual conditions is really important in the presenting problem and the treatment plan. Identifying risks, lifestyle changes, other services, and overlap of their social history or personal history that relate to the presenting problem or the care plan. Diagnostic tests or orders, referrals, and consults. These need to be specific. It needs to be done, ordered by the physician who is treating the patient for a specific condition that needs to be stated. What is that condition that the order is for? And as well as ordering it, the physician who orders it needs to have a record of the relevance, a record of the use, a record of the management of that result or diagnostic information or data collected and how it benefits the patient in the medical problem or progress of that condition. Recording observations of the physical exam or of the presentation of the patient or disease by body areas, organ systems, symptoms. The record should identify all abnormal finding, results, and state the relationship to this finding. Just to say that there's an abnormal lab is not enough for a coder to abstract that or for it to be considered relevant in the medical decision making or the complexity of the encounter. In part of the reduction of burden on the physician, streamlining documentation and requiring less overall is important to efficiency. So I've provided two examples here that we're going to discuss. One is of low complexity and one is of high complexity. And each of them represent what impact the new payment model for evaluation services could have on your practice. So let's discuss. As seen here in the first example, Chad is a 14-year-old white male who returns to our clinic for a 2-week follow-up. This says that he's an established patient. He was seen last month for a cough. The patient continues to have a postnasal drip with the intermittent coughing spells. Rhinorrhea is on exam, and the physician recommends to continue over-the-counter Robitussin, allergy and cough, 2 teaspoons, as needed. He's returned to the clinic in 2 weeks if it's not resolved. There is fairly low complexity in decision-making needed here. All of the information the coder needs is presented in the diagnosis and the treatment plans to return to the clinic in 2 weeks. Now let's take a look at the high complexity example. Sarah, she is 31. She's a black female that is new to the clinic after moving here last year. She presents with a 10-year history of underlying AIDS infection due to high-risk sexual behavior. She has complaints of abdominal pain, 3 weeks of coughing up blood, and difficulty breathing. On exam, she has a fever. She's hypercapnic and cachaic. Her exam was cut short due to a sudden onset and a patient seizure in the exam room that lasted 12 minutes. 911 was called, an ambulance arrived, and Sarah was taken to the hospital in stable condition for admit. Now, this is a very challenging case. Just the presentation of the patient alone says that. But what's unique about this complexity is that the medical decision-making component or element that we would normally expect or be required under the 1995 or 97 guidelines is absent. In today's standards, that would be a problem. In the future, in 2021, this will not be a problem because the physician will be able to collect and receive credit for the complexity of that visit. As you can see, the last statement says it was a complex medical history that is described. There's non-communicative in nature during the exam without accompanying records. This was a very challenging case for the provider, and it is obvious due to the extent of detail that is described within this example. The coder also has enough to process this claim and submit it for payment. The underlying HIV/AIDS due to high-risk sexual behavior presents one factor of complexity, as well as an immune deficiency status code that will be available in 2020 that would be added to this. The patient also has symptoms that the coder would be able to code in the absence of a final assessment. Abdominal pain, coughing up blood, difficulty breathing, all of those could be coded as a symptom for a professional in the outpatient setting. In the absence of the assessment, because the patient was taken to the hospital in an emergency scenario, the complexity is assumed to some degree. There is some time documented in the record, but it would not fit into the box of being able to bill based on time, as under the CPT standards or estimated time factor for a 99205, there must be in excess of 60 minutes spent with the patient. However, under the new imposed rules of 2021, this would constitute the high complexity that would be established by the documentation guidelines. While these two examples are quite extreme in the differences, and there are many evaluation management services and situations that fall in between that could pose challenging for both coders and providers. So think about reducing the effort of focus on the history and the presence of what the encounter represents in the progression of disease. Not only does the provider have opportunity to reduce the time spent in documenting unnecessary information, but to get the point across into the real nature of the encounter and the treatment plan, to represent additional services that may be rendered during the office or encounter by other clinical staff or personally that could be either represented by time or represented by additional documentation. These services, or some of these services, are here listed, not all inclusive, but each of these categories offer benefit to the providers and the patients and more revenue for the bottom line. Everyone wins when we work together. Thank you for your 15 minutes of time, and I appreciate you. My name is April Black, and I look forward to seeing you next time. Good day now. Bye.